Hello, my name is Alyssa Utai. I am a third year pharmacy student at UAMS and current public health student. Today I am presenting about health disparities and health inequities. I am going to address these questions. Which health disparities are being addressed in the condom use promotion program? Are these health disparities also health inequities? Are all health disparities also health inequities? And if there's a difference, what is it? Finally, identify appropriate reference groups for assessing the health disparities addressed in this program. So, this presentation is about the article Key Components in Planning, Implementing, and Monitoring a Behavior Change Communication Campaign that increased condom use among male clients of sex workers in southern India. India has approximately 2.5 million people affected with HIV, so the study focused on increasing consistent condom use among heterosexual male commercial sex clients. The research was conducted in 100 high priority towns in the province of Andhra Pradesh, Karnataka, Maharashtra, Tamil Nadu. And to start, I think it's important to address certain terms as they could be confusing. So, health disparity is defined as variations or difference in health status among certain groups of people. In contrast, health inequity are disparities in health that are systemic and avoidable, therefore considered unfair or unjust. Disparity is a dimensional concept referring to measurable quantities. Inequity is an optical concept expressing a commitment to social justice. Also, inequity describes the systematic and repeating patterns of disparities. Next, communities that shoulder a disproportionate amount of unequal health outcome are often economically challenged, racially segregated, and have fewer resources. I believe that this article especially showed an economically challenged area of the world, and it was racially segregated because it focused mainly on Indian folks, and they also had fewer resources. Additionally, I think it's important to provide examples of resources that enhance quality of life. These include safe and affordable housing, access to education, public safety, availability of healthy foods, local emergency/health services, and environments free of life-threatening toxins. Moving forward, the health disparities being addressed in the condom use promotion program are low socioeconomic status, population specific, and the presence of a disease, in this case, HIV. And this slide here is about health inequities. Health inequities, according to a recent journal publication, is defined as social differences in health, such as those based on race or religion, are considered health inequities because they reflect an unfair distribution of health risks and resources. So, this study was based in southern India and could be expanded to also compare or contrast another study with high rates of HIV transmission. So, I would agree that the health disparities that I addressed are also health inequities. Now, this slide here, I would like to contrast health disparity versus health inequity. So, another good explanation of health disparity is the differences in the presence of disease, health outcomes, or access to health care between population groups. And then another explanation for health inequity is the differences in healthcare that is avoidable, unnecessary, unfair, and unjust. An example of health disparity can include the HIV and commercial sex workers. And an example of health inequity can include poverty among heterosexual males in the cities listed. Next, I would like to go over the reference groups that helped assess health disparities. And I found it was the National AIDS Control Organization of India, the World Health Organization, and the Global HIV Prevention Group. And then finally, here are my works cited. I have links to the photos that I used and then 2 works cited. Thank you.